Welcome to This Week in Pediatrics. This week, we're covering 10 notable papers spanning critical care innovations in the NICU and PICU, common diagnostic challenges from seizures to ECGs, and a look at complex care in immunology and oncology. Let's dive in. We begin this week in the intensive care setting, with several studies aimed at optimizing care for our most vulnerable patients. A major nationwide trial from Denmark. The duration trial was a multi-center, non-inferiority study that enrolled late preterm and term neonates with culture-negative, probable early-onset sepsis. These were infants who were kept on antibiotics beyond 36 to 48 hours due to clinical signs or maternal risk factors, plus an elevated C-reactive protein. They were randomized to either standard care, which was 5 to 7 days of antibiotics, or an individualized duration. In the individualized group, treatment was stopped after just 24 hours without clinical signs of infection, as long as the C-reactive protein was declining and below 30. The results were clear. For the primary outcome of readmission due to bacterial infection, the individualized strategy was non-inferior, with only a 0.4% difference between groups. More importantly, the median total antibiotic duration was slashed from 6.8 days in the standard group to just 2.8 days in the individualized group. This study provides strong support for using a clinically guided strategy to safely and significantly reduce antibiotic exposure in this common clinical scenario. Also in the NICU, for infants with neonatal encephalopathy undergoing therapeutic hypothermia, sedation is often required. The DICE trial compared dexmedetomidine to morphine in this population. This was a phase 2 safety and pharmacokinetics trial that randomized 48 infants. The investigators found no statistically significant differences in baseline characteristics, hospitalization outcomes, or adverse events between the two groups. The pharmacokinetic analysis revealed that cooled infants had lower clearance and a smaller volume of distribution for dexmedetomidine compared to what has been published for non-cooled infants. The clinical takeaway is that dexmedetomidine appears to be a safe alternative to morphine for sedation during therapeutic hypothermia. But clinicians should be aware that its metabolism is altered in these patients, which may influence dosing. Staying in the ICU, a secondary analysis from the Journal of Pediatrics looked at a less invasive way to monitor respiratory status in infants with congenital diaphragmatic hernia. The study compared the invasive oxygenation index, or OI, which requires an arterial blood gas, with the non-invasive oxygen saturation index, or OSI, calculated using pulse oximetry. In a cohort of 61 infants with substantial hypoxemia, researchers found a very strong correlation between OI and OSI, particularly when using productal oxygen saturation. This suggests that the non-invasive OSI, based on productal oxygen saturation, can serve as a suitable alternative for OI in clinical trials and potentially in clinical management, reducing the need for frequent and painful arterial blood draws. Finally, in a global health context, a study in pediatrics validated a pediatric early warning score, or PEWS, for children hospitalized with complicated severe acute malnutrition in Niger. The novel score uses 9 clinical indicators to categorize patients by risk. The results showed a strong predictive ability. Children in the highest risk red category at admission had a risk of death during treatment that was more than 2.5 times greater than those in the green category. In a time-varying analysis, being in the red category at any point was associated with a nearly 12-fold higher likelihood of dying in the following 48 hours. This provides strong evidence for using this PEWS tool to effectively identify the highest-risk children in resource-limited settings, allowing for more intensive monitoring and intervention. Next, we turn to common diagnostic challenges and how clinicians can sharpen their skills. A frequent and often difficult question in pediatrics is differentiating epileptic seizures from paroxysmal non-epileptic events. A systematic review and meta-analysis in developmental medicine and child neurology aim to identify key clinical clues from 40 studies involving over 3,000 patients. The analysis found that certain features were significantly more frequent in epilepsy, including behavioral arrest in young children, hypermotor activity and tonic semiology in older children, and spasms across all ages. Conversely, some features were almost exclusively non-epileptic, including movements involving agonist-antagonist muscles, stereotyped movements, asynchronous motor events, and tremor. While video EEG remains the gold standard for diagnosis, this review provides a practical, age-stratified toolkit of semiological features to help risk stratify patients at the bedside. From clinical semiology to interpreting diagnostics, another study in the Journal of Pediatrics evaluated an online educational tool for improving pediatric electrocardiogram interpretation. This multicenter study used a deliberate practice and mastery learning approach, where 345 pediatricians interpreted cases from a bank of 400 ECGs until they reached a performance standard. Initial accuracy was modest, especially for selecting the most specific diagnosis, which was correct only 45% of the time. However, after a median of about 6.5 hours of practice, accuracy improved significantly, with a nearly 20% gain in making the correct specific diagnosis. The study also identified the most challenging diagnoses for pediatricians, including ventricular hypertrophy, Brugada sign, prolonged QTC, and ischemia or pericarditis. This work demonstrates that structured practice with feedback is an effective way to improve this critical skill, and highlights specific areas where pediatricians need more training. This gap between knowledge and practice is also evident in the management of a very common condition, bronchiolitis. A retrospective study from the Journal of Pediatrics looked at care in 21 community emergency departments in Northern California. Among over 6,000 children with uncomplicated bronchiolitis who were discharged home, guideline discordant care was prevalent. 62% of patients received at least one test or intervention that goes against American Academy of Pediatrics guidelines, most commonly chest radiography and albuterol. This discordant care was associated with a significantly longer emergency department length of stay, adding nearly an hour to the visit. These findings suggest that despite clear guidelines, the de-implementation of low-value care for bronchiolitis remains a major challenge in community settings and contributes significantly to ED overcrowding. Finally, we'll look at 3 papers tackling complex care in rheumatology, genetics, and oncology. For children with juvenile idiopathic arthritis on immunosuppressive therapy, the use of live vaccines is a perennial concern. A systematic review in the European Journal of Pediatrics synthesized the evidence for MMR and varicella vaccination in this population. The review, which included 9 studies, found that the vaccines were generally safe in clinically stable children, with no consistent increase in disease activity or serious vaccine-related complications. The main concern was not safety, but immunogenicity. 5 years after an MMR booster, seroprotection against measles and rubella was particularly low, only 60%, among children receiving biologic DMARDs. Similarly, varicella vaccination induced lower antibody levels than in healthy controls. This review supports the cautious use of these live vaccines in stable JIA patients, but underscores the need for individualized timing and consideration of post-vaccination serology, especially for those on biologics. Shifting to genetics, a qualitative study in the Journal of Pediatrics explored parental experiences after a child is diagnosed with a cancer predisposition syndrome or CPS. Researchers interviewed 25 parents of children with conditions like Li-Fraumeni syndrome who were diagnosed before age 8 and had not yet developed cancer. Parents described receiving the diagnosis as emotionally challenging, but also felt empowered by the ability to engage in proactive cancer surveillance. They acknowledged the significant logistical, emotional, and financial burdens of surveillance, but most felt these were outweighed by the medical and emotional advantages. Notably, the majority of these parents endorsed the implementation of population-based genomic newborn screening for pediatric cancer risk. This work provides valuable insight for counseling families and suggests that despite the heavy burden, parents value early identification of cancer risk. And finally, a look to the future of pediatric oncology. A preclinical study in pediatric research developed a novel immunoconjugate for childhood acute myeloid leukemia. The strategy aimed to solve the problem of relapse driven by leukemia stem cells. Researchers created a molecule that combines a BCG heat shock protein designed to stimulate an immune response with an anti-CD123 monoclonal antibody, which targets a marker on leukemia stem cells. In lab experiments and in a mouse model, the conjugate significantly enhanced T lymphocyte activity against AML cells, reduced tumor volume, and induced T-cell infiltration into the tumors. While this is an early-stage study, it presents a promising new therapeutic strategy for targeting minimal residual disease in relapsed or refractory childhood AML, laying the preclinical foundation for a new class of drugs. If you only have time for one paper this week, make it the duration trial on antibiotic duration for culture-negative sepsis. It provides strong, non-inferiority evidence to support a shorter, clinically guided antibiotic course, potentially reducing treatment for these neonates from a week to just 3 days. Here are the key takeaways from this week in pediatrics. First, for late preterm and term neonates with probable culture-negative early-onset sepsis, a clinically guided approach stopping antibiotics after 24 hours of stability with a declining CRP is safe and dramatically reduces antibiotic duration. Second, in the community ED guideline, discordant care for uncomplicated bronchiolitis remains common, particularly the use of chest X-rays and albuterol, and is associated with significantly longer lengths of stay. Third, key semiological features can help distinguish epileptic seizures from non-epileptic events at the bedside. Features like tonic posturing suggest epilepsy, while movements involving agonist-antagonist muscles or stereotypes strongly suggest a non-epileptic cause. Fourth, for children with stable JIA, even those on biologics, live MMR and varicella vaccines appear safe, but protection may be less durable. Consider individualized timing and post-vaccination serology in high-risk patients. And fifth, pediatric ECG interpretation is a skill that requires deliberate practice. An online mastery learning approach can significantly improve accuracy, especially for high-risk findings like ventricular hypertrophy, Brugada sign, and long QTc. That's your roundup for this week in pediatrics. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And for audio briefings on your own clinical questions and papers, visit audioscholar.cc. This is an automated summary generated by artificial intelligence which can make mistakes. Always review the original source materials.